Right. Good evening. Thanks very much for joining me on such a nice evening. Hopefully, some people are sitting in the garden. There's nothing wrong with having a glass of wine. Nobody can see you, so that's fantastic. I'm Mark Frame. I'm an orthopedic surgeon from University Hospital Southampton. Also operate in the Spire Hospital and in the Wessex Nuffield. So tonight, I thought it would be a good opportunity just to go through, as the title suggests, the different options that take you towards a total knee replacement if you have osteoarthritis of your knee. And often it doesn't end in a total knee replacement. All the different options that we have that are available, I think a lot of people feel that it's a very binary set of circumstances when you have arthritis in your knee. It's either do not an awful lot or have a major operation like a total knee replacement. That's just not true nowadays with all the different options that we have, be that conservative management, etc. So I'm going to take you through it bit by bit. Before we do that, a little bit of background just about me. Clearly, if you've not met me before, I'm not from the south coast of England. I'm originally from Scotland, from Glasgow, went to university up in Aberdeen, internationally fellowship trained. So I've been all over the world in different places learning my trade. Been to Texas, I've been to France, and actually it's what brought me down to Southampton was my fellowship down here. My practice in Southampton is pure knee. My elective practice is just knee. That's sports injuries, pediatric knee, total knee replacements, partial knee replacements, sports injuries. I've got particular specialist interest in patellar instability and wobbly kneecaps as well. So, moving on with the topic, the plan for this evening is to go through osteoarthritis. I know it's probably something that's been done to death and you understand what it is, but it's really important, I think, just to cover that again. Have a look at the non-surgical options and then the surgical options, and then break down all of those different things into the different types of non-surgical options and all the different kinds of surgeries that we can do now. And at the end, really address some of the more novel things that you might have heard of, and really understand what they mean and whether they're a valid option, whether they're going to be a valid option, or whether it's just a bit of snake oil. So we'll cover some of those later. So the etiology of osteoarthritis, it's a really complex problem. It's not just wear and tear. There's constitutional factors. So your age obviously plays a big part in it. The older you get, the more likely you are to have osteoarthritis, but not universally. There are many people that are young that end up with osteoarthritis for different reasons. Unfortunately, it's another thing for girls. Being a girl sucks. That's what my wife always says. And it's the same thing with osteoarthritis. The female sex, a greater preponderance of a chance to get osteoarthritis. Family history is really, really important. You tend to see people come in and they say, well, you know, my granny, my uncle, my cousin have had total knee replacements or they've had surgeries. So it really does run. There's a very strong family history involved in osteoarthritis. Obesity plays a huge factor. So clearly, much like any kind of mechanical problem, whether it's in the human body or whether it's your car or anything else, the greater the forces being exerted across a joint or being asked of a structure, the more likely they are to have problems, have damage. Local mechanical factors. So we know that trauma plays a big part in development of osteoarthritis. That smooth, shiny joint surface within your knee, if you have a fracture that involves that joint surface, or dramatically changes the shape and the alignment of your leg, putting more force on one bit of that joint surface than another, the greater the chance of having wear and tear and osteoarthritis developing within the joint. As a trauma surgeon, we see that quite a lot. I kind of explain it to patients, you know, it's like breaking a mirror. You can glue that mirror back together and it can be shaped like a mirror again, but it's not smooth and shiny like it was at the beginning. And that unevenness of the surface and the pathology that's caused by that increases your chance of osteoarthritis. We also know within the literature that generalized laxity plays a part and is a factor in increasing your risk of osteoarthritis. That generalized laxity can be because of the way that you are, or whether that can be a generalized laxity because you've damaged some of the ligaments, giving you an abnormal movement of your joint. That articular cartilage likes to glide and slide, that sheer forces of twisting and turning on a joint surface, because you've got instability perhaps from not having an anterior cruciate ligament, doesn't treat the cartilage well and can increase your risk of arthritis. Genetic factors kind of ties in with the family history. We know that twin studies show a family prevalence of about 35 to 65%. So that gives you some idea of the genetics involved in developing osteoarthritis. So the basic science of it: the articular cartilage in your joint is avascular, so it doesn't have a blood supply. It gains its nutrients and its all the different things that it needs to repair from the synovial fluid, rather than a direct source from blood supply. It's alymphatic and it's aneuroprotective tissue, so it doesn't have any nerve supply, doesn't have a lymph supply. So you can understand that when that cartilage is damaged, your body has a really hard time reproducing the cartilage that's there and repairing itself. And that's our biggest problem in orthopedics. The person that comes up with a way of being able to encourage your body to recreate true hyaline cartilage is going to be doing really very well. We're still not there, haven't really been able to achieve that, and unfortunately we're stuck with doing much more mechanical replacement of that cartilage rather than trying to encourage that cartilage to regrow. And we'll go through some of that new science that's coming through that's trying to achieve exactly that. It's very resilient to wear, and it's very highly compressive stiffness. So it's kind of non-Newtonian because you've got lots of water in it, and you impact cartilage quickly and it rebounds and bounces. It's very, very incredible structure, because if you can imagine, that can last you your entire lifetime, 100 years. There's not very many bearing surfaces in anything that we know that can survive daily punishing for 20, 30, 50, 100 years. So it's very incredible stuff. Water accounts for 65 to 80% of the wet weight of cartilage. The best way to think about it is a huge tangle of proteins that make up that cartilage, and within that big tangle, water is stored, and it's stored in a very stable manner to allow it to be very low friction and to slip and slide and glide. So that 10% of wet weight of cartilage is made up of collagen, which provides the tensile strength. So that's the strength of pulling that cartilage apart. Diagnosis of osteoarthritis. Again, this is something that's bread and butter. I don't want to teach you something you obviously already know, but the diagnosis of knee OA in particular can be made predominantly really just on the history. It's very classical, the way that people describe osteoarthritis. The clinical examination is very relevant as well, but it's really just backing up what's already been told you by the patient. Confirmed by radiology, X-rays and MRs, and we'll go into the benefits of both of those in a minute. The importance of a precise diagnosis helps to rule out other causes of knee pain. Because of the way that your neurological supply and sensory supply to your knee, it can be often confused with other things. So hip pain and osteoarthritis of your hip will often radiate to your knee, and it can be so distant from your hip and actually manifest with no hip pain at all that there are circumstances where patients have come in complaining bitterly of knee pain. You take an x-ray of their knee and they have relatively minor, moderate osteoarthritis that doesn't really fit. And that's really important when you're taking a diagnosis and trying to work out what the biggest problem is to make sure that everything fits together properly. If something doesn't look quite right, just think outside the box. So if somebody's got very severe pain and severe immobility and you take an x-ray and it's not too bad, there's a good chance that it's something else that's causing pain. And an x-ray of their pelvis is really useful, because there are circumstances, like I said, where patients have actually gone ahead and had joint replacements in their knees, when actually what's going on is the degenerate change in osteoarthritis in their hips. So it's not unusual to have pain radiating from somewhere else. The typical symptoms, often really intermittent and cyclical. Particularly at the beginning, patients will be absolutely fine, and then all of a sudden have significant pain, discomfort, immobility, a swollen knee that stops them moving, doing things. Call for help, either through the GP, through a physio, through us, and by the time they come and see us, things have settled down. And that's a very typical pattern of osteoarthritis, where you have good times and you have bad times. And I always say to folk, when the good times become few and far between and the bad times become the norm, is when you start to want to do something about it and seek some help. So a dull ache, often swelling with an effusion within their knee, beginning to get loss of range of motion, tends to come further down the line other than in an acute situation. You can have deformity of the joint, and that's where the physical examination of the knee really kind of comes into play. So it's really important that you look at the body habitus, the shape of the patient, not just with regards to their BMI, but the overall, whether they have rotational malalignment, whether they have a varus or valgus deformity, and we'll show you a picture of that in a minute, and their gait pattern, the way that they walk. So we will often talk about an antalgic gait, which is just a word for saying that they've got a painful gait. And the typical limp that you see with somebody with an antalgic gait, all that is and what defines that gait is that they want to spend as little time as possible on that knee that gives them pain. And so through the gait cycle, as soon as they're on the painful leg, they want to get off it again. And that's why you have that typical painful limping gait that patients will have, because pressure through that worn out joint gives them pain. Also, if they're walking with a knee that's not completely straight, they will often have a limping gait as well, even if it's not particularly painful, but that loss of range of motion has an impact on the way that they walk. So it's important to see them standing as well as lying down, and you're looking for an effusion within their knee, looking for point tenderness around the knee joint, moving the kneecap in the trochlear groove, so moving the kneecap in that groove and feeling for whether you've got a nice slipping and sliding feeling underneath the kneecap, or whether you have crunching and grinding and pain of bone rubbing on bone or uneven cartilage rubbing on uneven cartilage. Also tenderness around the joint line, so very much feeling that joint line and seeing whether there's pain on the medial side or on the lateral side, and that will help pinpoint where that wear and tear and the osteoarthritis within their knee is. None of these individually are particularly sensitive, but it's like putting a jigsaw together and trying to work up a bigger picture that you can then compare when you have your imaging. The other thing you want to look for is ligament instability. So some simple tests, doing a Lachman's or an anterior draw for anterior cruciate ligament or posterior cruciate ligaments. Generally, when somebody has advanced osteoarthritis, even if they've had a ligament injury in the past, that osteoarthritis tends to get rid of the inherent laxity within their knee, and they're far more likely to be stiff, and actually examining for an ACL or a PCL might be quite difficult at that stage. Probably more importantly would be the collateral ligaments, and just making sure that the lateral ligaments on varus or valgus testing are intact. You can see the limb alignment probably best on standing, and that weight bearing is really important because it will often accentuate any kind of wear and tear and bring the joint together that you might not see when they're lying down. A varus deformity is suggested of medial compartment involvement, so that's when you see somebody that's very kind of bow-legged, while a valgus malalignment is much more to do with the lateral compartment, and that's when patients look quite knock-kneed. Now, there's obviously a very grey scale of what's normal. So if you stand at a bus stop, you'll often see people with knock knees and some people with bow legs, and they don't have any pathology. And that's where having two legs is really important, and you can have the check for symmetry and compare it with their other limb. Range of motion is important to test. Both active and passive should be noted. Probably the most difficult thing to resolve when somebody has osteoarthritis and you want to do something more definitive with them is that lack of extension. And that tends to point that they have much more advanced arthritis. People tend to be reluctant to bend due to pain, but that is generally not restricted by osteoarthritis. It's generally the extension that you lose. And it's also important to examine the joint above and below. So have a look at their ankle, make sure that they don't have any deformities or problems with their ankle or osteoarthritis of their ankle, and moving their hip above. Again, really just being very cautious to make sure that the knee pain that they have is from their knee and not radiating from their back or from their hip. So here's a quick image. You can see what's generally described as normal. I suppose it's kind of the median of what we would expect people to look like. You can see the varus deformity in the middle. So their ankles will meet and their knees will often not touch each other, whereas the valgus deformity is that their knees will make contact before their ankles will be, and that's that knock knee. And again, there's a wide range of normal. So I would take the comment on this image that normal is the one on the left. Normal could be any of those different things. I'm quite knock-kneed. Footballers tend to be valgus because it gives them an advantage for speed. They're all normal, but it potentially puts you at risk of a different kind of wear and tear within your knee because of the way that the mechanical axis and the weight passes down through your knee joints. The normal axis, your weight, if you were to drop a plumb line from the middle of your hip heading down to the middle of your ankle, you can imagine that's coming down through the central portion of the knee joint with the pressure and force being spread over both sides of the joint, both the medial and lateral articular surfaces. Whereas if you're varus, so if you're bow leg like the chap in the middle, and you drop a plumb line from the middle of your hip to your ankle, that weight bearing axis will tend to pass more through the medial joint compartment, and therefore there's more force and pressure proportionately going through the medial side as opposed to the lateral side if you were to drop that weight axis for the person who's valgus. Clearly, as you wear the medial side or the lateral side and you become more varus or more valgus, then it's kind of a negative cycle. So somebody who's wearing out their medial compartment becomes more varus, which then puts their weight-bearing axis further through the medial joint line, which puts more force through that side, and so on and so forth. So actually it potentially gets worse and exacerbates their pain and their problems. Investigating somebody, it's really, really important, even before somebody's been referred. If somebody's complaining of pain in their joint, it's really important, really easy for us to be able to get an x-ray. It gives you a lot of information with regards to osteoarthritis, and just make sure that there's nothing else going on. I always tell this scare story, and it's not really just to scare anybody, but it's really important to understand that there are other pathologies and not just to assume, particularly if you're going to start treatments, for instance, a joint injection, etc. We had a patient who had gone back and forwards through physio, through their GP, to the emergency department with knee pain. The assumption, and almost a bit like Chinese whispers, had been led all along that this lady had osteoarthritis. And it turned out after she'd been investigated in hospital and had an MRI scan that she actually, unfortunately, had a sarcoma of her knee. So although incredibly rare, for the sake of getting an x-ray before you make any assumed diagnoses, I think that's really important. 2 orthogonal views, which just means 2 views in 90 degrees perpendicular to each other, so you can get a good view. The AP and the lateral views show the joint surface at different angles, and also it's important for us to be able to see the patellofemoral joint. Sometimes in clinic we will also organize what's called a skyline view, which is to look behind the kneecap, because if you've got isolated osteoarthritis of your patellofemoral joint, then an x-ray taking an AP wouldn't show you that. It would look like a relatively normal knee, but as soon as you take a lateral or you take a skyline view, then you see that it's very, very worn and you've got loss of joint space behind the kneecap. So that's why multiple views are really, really important. The things that we're looking for are loss of joint space. So an x-ray is really a bit like taking a negative of a photograph, because all we're seeing is the bones and everything else is assumed. So if there's space there, we assume that that space is caused by there being articular cartilage on the surface of the joint, as well as the meniscus. And as you develop osteoarthritis and you lose that articular cartilage, then that joint space gets narrower because it allows the bone surfaces, the subchondral bone, to come closer to each other. You get subchondral sclerosis, which is when the bone becomes whiter and more dense because it's laying down more bone because you've got that surface rubbing off each other. You get osteophytes, which are the extensions of bone that form, these small spurs that form at the edges of the joint. That's your body's way of trying to increase the surface area of the joint to reduce the force over area, so proper physics, but it doesn't work. But it's a good indicator that you've got osteoarthritis and something to let us know what's going on. Obviously, the deformity that we talked about that you can see clinically, you'll also potentially be able to see on an x-ray. MRI is definitely becoming much more used. I almost always MRI knees, and that's because we've got lots of different options with what we can do. So it's really important not just to see that you have arthritis, but to define whereabouts in your knee that arthritis is and how severe that arthritis is in the different locations of your knee, trying to find out whether you have isolated pathology within the joint. Here's a little photo on the left which shows you the importance of two views, so you know that you're seeing the real information. And that's an example of an osteoarthritic knee on the right. You can see the loss of joint space in the medial joint compartment, that subchondral sclerosis where it looks much more dense, the bone. And you can see that deformity. So that patient clinically would look quite varus or bow-legged. And the lateral view, again, you can see the two posterior condyles of the femur, and the one on the medial side is touching with loss of joint space. The lateral side, there's still a gap. And the patellofemoral joint, a little bit more difficult to interpret, but you can see that there's a gap in there as well. So the treatment, we start on a ladder, and you start from non-operative. So the aim is to do as little as you possibly can to give patient the relief of their symptoms. Ultimately, whatever we're doing, the aim of the game is to get rid of their pain, to allow them to live their life a bit more normally. And if that can be done in a safe way with minimal risk, then that's ideal. So I often get patients that come to see me that say, oh, I don't want to take painkillers, I don't want to do this, I'd rather have an operation. I always find really challenging, because ultimately, whether you're having an operation or whether we're giving you painkillers or whether you're having an injection, none of them are giving you back a normal knee. Ultimately, what we're trying to achieve is to give you pain-free function to be able to carry out your life in a positive way. So I'm sure you guys are the masters of all of this. You're definitely at the stage before they see us when it gets much more severe. But lifestyle modifications, probably the most difficult thing to try and convince patients to do is to change anything that they do in their lives. So you want to change to closed chain type activities and exercises. So instead of running, being on a bike, being in a swimming pool where you're weightless, something where your foot is in contact with the machine or the equipment through the entire range of motion. So if they're going to go to the gym, being on an elliptical trainer, for example, rather than on a treadmill. If they're overweight, try and lose some weight. Again, one of the most difficult things to try and get patients to do. There's plenty of evidence that not only does it reduce your risk of developing symptomatic osteoarthritis, it also, if you are going to head for any kind of treatment, has a massive impact on their morbidity and potentially your mortality from having surgery. So although there are some very specific BMI levels that are put in place, the basis and the evidence for those is very real. And I've had patients, and I've seen patients that have had complications post-operatively that can only be put down to the fact that they are obese and have a high BMI rather than any other medical problem. So it's really very significant. And for instance, if you think about your patellofemoral joint, which acts as a pulley, so it's a multiplier of work of your quads muscle, every kilogram is multiplied by 4 to 6 through your patellofemoral joint when you're weight bearing on a bent knee. So if you imagine losing 1 kilogram has a massive impact on the potential pain that you might have in your patellofemoral joint or in your knee. So it's not us just being grumpy and trying to encourage people to try and lose weight. There's real evidence behind that, and it will have a massive impact on patients' pain and ability to manage their knee, both pre and post-operatively if they end up that far. Orthotics, a bit of a difficult one. There's lots and lots of braces that don't do any good, and I'd be very cautious about encouraging patients to have a brace. Most of those sort of things that you can buy on Amazon will have no impact whatsoever. Doesn't mean that there isn't a placebo effect or a feeling of comfort from having a tight knee strapping, like these neoprene knee braces on your knee. It doesn't give you stability. It doesn't change things. If it gives you some relief and the patients like it, then it's doing them very little harm. And I'm quite happy for them to do that, but I'd be cautious about spending lots of money on any kind of fancy brace. The only kind of brace that has some evidence, and that's through one of the recent Cochrane reviews, is demonstrated that you can get improvements in your pain and function using an offloader brace. So that's a very specific type of brace that's a bit like imagining you've got 3 points of fixation. It's like somebody's hand trying to open up and push against and offload the side where you've got that wear and tear. So looking back at that x-ray where they'd worn out the medial joint compartment, the brace is trying to open up that medial joint compartment to take some of the pressure off that So when they're in the sort of swing phase of their gait, that there's pressure released and actually improves their pain. So from a logical, mechanical perspective, it makes sense why a brace like that might work. They're quite expensive, but in the circumstances that we have at the moment, where the waiting lists can potentially be up to 18 months, that something like an offloader brace might be an option for somebody who's struggling with pain but has an operation or even just an appointment to come and see somebody well into the future. Moving through the rest of the non-operative pathway, physio, there's very good quality evidence that muscle strengthening and aerobic exercise programs are beneficial in the management of OA. However, ultimately, if somebody's got very severe osteoarthritis where you have bone-on-bone articulation between the joint and inflammation due to that bone-on-bone articulation within the joint, it's a difficult stretch to imagine why building your quads or increasing your movement within your knee is going to have a particularly positive impact on that. Certainly won't do you any harm if you're heading for surgery, and it will build up your quads to allow that recovery process to be a wee bit easier when you do lose some of your quads. However, it's not going to be a definitive way of managing your pain. In the very early stages of degenerate change, absolutely the physio and muscle control and building your muscles is very beneficial. But when you get towards the end of the degenerative process and wear and tear, then physio probably has less of an impact. You then come on to the pharmacotherapies that are involved. We all know simple non-steroidals have use. It's difficult to encourage patients to take them regularly. It's probably not a great idea on a regular basis. And I always try and take patients through the analgesic ladder, as I'm sure most of you do in primary care. Patients are often very, very, very resistant to taking painkillers. I think some people feel that it's some kind of failure to be taking tablets rather than doing something more definitive. I really try my best to encourage patients to take them. Paracetamol, starting at the very bottom, is probably the best way to go. Most patients tend to not take paracetamol, tend to take nothing, have a lot of pain, go and see somebody about it. Because they're complaining of a lot of pain, they tend to get much harsher, stronger, further up the analgesic ladder therapies. We'll take a non-steroidal, we'll often have reflux, not like that, or take opiates and have all the side effects of opiates being constipated, slowing down their gut, and being sleepy, and therefore have the horrible side effects and then stop taking painkillers altogether. And actually, what would be ideal would be to start with something like paracetamol, and rather than taking it like most people take it, which is now and again reluctantly, where it's going to have very little impact, is to take it regularly. I tell patients that I want them for 2 weeks to take paracetamol, 2 tablets, 4 times a day, as if they're taking a course of antibiotics. And only at that point, if they feel that the paracetamol isn't achieving what they want, do I kind of accept that they've tried things. So I'm quite harsh with that. But paracetamol is something that we use, and it's a fantastic painkiller if taken correctly. It's used post-operatively IV. From being an efficient painkiller, it's up there with morphine if taken correctly. So, it doesn't have any addictive qualities. It doesn't cause problems with their tummy. It doesn't slow your gut down. Doesn't make you sleepy. Isn't addictive. So patients really need to try that first and then build upon that if they need to. Intra-articular injections are another one that's often done in primary care and in physio, as well as our clinics. There is some evidence. It's interesting that it's one of those things that is done such a lot, but actually, when you look at the evidence isn't fantastic. And actually, from one of the Cochrane reviews, it said that they were effective at getting rid of some pain, but only for a week, which is really at odds from what we think, and I think what patients think, where they will have an injection that they feel lasts 3-6 months. I don't think it's the injection that's lasting for 3 or 6 months. I think the steroid is essentially settling down some of their inflammation within their knee, that's giving them some respite from the pain within their joint to allow them to start moving and get out of that cyclical phase of pain that they have with osteoarthritis. Hyaluronic acid is another injectable that we use quite regularly. The aim of that is to act more as a viscosupplement, so to act as a shock absorber or like a lubricant within your knee. It has an analgesic, anti-inflammatory, and a bit of a chondroprotective properties, as it's starting to allow your knee to slip and slide and glide. there was a review and multiple studies with regards to hyaluronic acid that showed that actually it does reduce pain and increase function. And actually, there are some studies that show that it's for a much longer period than a steroid, so for 3 to 6 months. Interestingly, it depends where you are as to whether you can have that on the NHS. There are some trusts that it's allowed. There were some trusts that it was allowed and now it's no longer allowed. I think cynically, it's probably not allowed because it's expensive, not because it doesn't work. So, for instance, Durolane or Ostenil, these are two of the kind of brand names, the most common injected hyaluronic acids, cost between 80 to 120 pounds for an injection, whereas a steroid's a few pounds. So I do think that's possibly playing into the decision-making process behind whether they're available or not. But they do work. Other more novel therapies for injecting into people's knees, patients quite often will ask about stem cell injections, PRP. There's lots of different names for these things. Ultimately, what PRP or these sort of stem cell injections are drawing blood from the patient, spinning it down, taking that platelet-rich plasma that's there, that yellow layer, and using that as a treatment within their knee to help with inflammation and the osteoarthritis. There's no doubt in my mind that the benefits of these will come out in time. We don't really understand exactly why they work or what pathologies they work best in. But for instance, there's a meta-analysis of 14 randomized controlled trials involving nearly 1,350 patients. And it's interesting that this was being compared with hyaluronic acid, which is already something that's not dubious, but doesn't have a massive impact. And it showed that they were pretty similar. So it's not a hugely high bar for PRP to meet. It's certainly not the wonder drug that everybody hoped it would be. And it's often sold as to lots of patients. And again, I would be very cautious of encouraging patients to spend large sums of money to have stem cell injections or PRP type injections. There are certain circumstances that they are useful and certainly worth trying, but it's not the cure to everything. There's another kind of injection that's been done, which is called lipogems, which is similar kind of stem cells or processed plasma that comes from fat cells. Again, very minimal evidence, but it's incredibly expensive. So again, I'd be very cautious of any promises being made about any of these biologic type treatments on the market. Now, if you've got a patient who's exhausted all of those things, they've been to physio, they're taking painkillers regularly, they've had injections, it's really not dealing with their pain, they're having significant impact on their normal day-to-day activities, they're now having to think about simple things that they can't do. And we get the wide range of patients. So we get the patient that can't get out of a chair comfortably, that can't climb the stairs more than once during the day because it's too sore, is unable to really go down to the shops or beyond the gate of their house, who will come and see us, and that's perfectly reasonable. We also have the other end of the spectrum where people's expectations are slightly different, where they aren't able to do the 30 miles a week running that they used to do, aren't able to play 5 sets of tennis and have some early degenerate change and want to do something about it. So it's a huge cohort of patients that we need to be very carefully deciding who gets what and when, because not all of these treatments do the same in everybody. It's very much patient selection and doing it at the right time that achieves the best outcomes. So it's not the mechanics of doing the operation. I do the same operation over and over and over. It's the patients that you do it on, and choosing those patients wisely is what gives you the best outcomes that you can achieve. So osteotomy is something that was very popular in the past and has had a bit of a resurgence. Ultimately, going back to looking at the x-rays that we were describing before, where somebody has predominantly medial arthritis, where they have a varus deformity, so they have that bow leg deformity, and we talked about the mechanical axis, so that's the weight axis of where that plumb line would come down through their knee. What we want to do, and what you're doing with an osteotomy with a medial one, is that you'll often do a realignment. So you do a cut and a wedge that you open up in the proximal tibia, and that's realigning the leg so that that weight-bearing axis, instead of passing through the worn-out surface on the medial side of the knee joint, is now running through the middle of their knee or just off to the lateral side to offload that degenerate wear and tear. It doesn't put cartilage back where cartilage is gone. What it's doing is offloading that area that's damaged to give them pain relief. We know that evidence has shown that osteotomies do really very well, and actually they will often last as long as a joint replacement, and they're very useful in the younger patient population, the very active patients that still need to use their knees and will be using their knee a lot in their job or heavy lifting or that sort of thing, where a joint replacement doesn't last forever. It is a bearing surface that will eventually wear out, or the metal implant where it's implanted into the joint will eventually become loose, or the rest of the knee, if it's a partial knee replacement, could potentially degenerate. And the longer that you have to live and the longer you have to use your knee, and the more you use your knee, the more likely those things are to happen, and the more likely you are to require something like a revision arthroplasty, which is a much more complex procedure. And if there's something that we can do that will potentially last you possibly forever, or if it doesn't last you forever, gives you 10 years of excellent pain relief to allow you to do your job, and then ultimately you come to a joint replacement when you're 65, 70 rather than at 45 or 50, then that's clearly a much better set of circumstances. Doing an osteotomy doesn't spoil the possibility of doing a joint replacement in the future. A lateral osteoarthritis, a valgus knee, so that knock-knee deformity, generally speaking, requires a distal femoral osteotomy. So rather than one at the top of your tibia, you have a wedge either taken out or opened, depending on where the deformity is, of your distal femur. Again, realigning things, taking you from that knock-knee position where the weight-bearing axis is passing through the lateral side and moving that weight-bearing axis towards the middle or the medial side of your knee to offload that degenerate arthritis and help with the pain within your knee. So again, as with every surgical procedure, patient selection is absolutely key, and it's choosing the right people that this does well with. We know that obesity, again, rearing its head is something that is a negative for this surgery, and also advancing age. So the older you are, the less likely you are to do well with an osteotomy. It's also a slightly more difficult operation to recover from. It tends to require a longer period of time off your feet. It can often be a little bit more uncomfortable than having a joint arthroplasty, and it may require you to be on crutches for longer. And it's a controlled fracture that's done by us that ultimately your body needs to heal, and a long bone of your femur or your tibia will often take up to 3 months to be healed. So it isn't a quick fix. It tends to be a bit more complex to recover from, but there's certainly a group of patients that do incredibly well from an osteotomy, and it's a really valid choice for some patients. There's an example of what I was discussing before. So you can see on the left-hand side, that yellow line represents the weight-bearing axis. So that's the mechanical axis of the leg and the body. You can see that from the center of the femoral head down to the middle of the ankle, and you can see that line passing through the medial joint compartment. The patient has then had a high tibial osteotomy. You can see the metal plate and screws that are holding that osteotomy open, which has given them a straighter leg. And now that blue line represents the weight-bearing axis through their knee, and it's now passing away from the medial side towards the middle or the lateral side of their knee, taking the pressure off that worn out surface. The one on the right is the opposite. So you can see they're quite knock-kneed to start with, and then the distal femoral osteotomy, giving them a much straighter leg, and you can see that mechanical axis passing much more centrally through the joint rather than through the worn out lateral compartment. We then move on to partial knee resurfacing or replacement. You might have heard two of those terms. They are exactly the same thing. It's semantics. So if a patient comes to you saying, no, I don't want a partial knee replacement or a knee replacement, I want it resurfaced, it's purely semantics. There is no difference between a partial knee replacement, a medial compartment uniarthroplasty, or a resurfacing. The reason that the term resurfacing, I think, is probably a much better term to describe what this is because unlike a total knee replacement where you are changing a huge amount of the mechanics of the knee, so you have control over the changing the patient's tibial slope. You take away the ACL, often the PCL. It will not feel and move the same as their original knee. Even the best total knee replacement in the world, most patients will be aware that they've had a total knee replacement. It may achieve the goals of getting rid of their pain, but it certainly in most circumstances does not feel like their own knee. With a partial knee replacement, be that a patellofemoral, a medial, or a lateral one, ultimately what we're trying to do is return the knee back to what it was before they had osteoarthritis. So where that articular cartilage has been worn down, you replace that with the metal cobalt chrome on the femur. The tibial side is then replaced with a small titanium plate, normally with a bearing surface of high molecular weight polyethylene, so you have metal sliding on plastic. We don't take out the ACL. You need your ACL to have a partial knee replacement. You don't touch your PCL. There's minimal change of alignment of their leg, and patients tend to feel that it's much more like their own knee was before, just without pain. So it does restore that varus or valgus alignment that they have back to their normal constitutional alignment. Like I said, it doesn't remove the ligaments. They have a better range of motion normally than a total knee replacement. Now, that's not universal. There are some patients that have fantastic range of motion with a total knee replacement, but more often than not, a partial will give you a much more symmetrical knee with the opposite side with regards to your range of motion. It's a quicker procedure. That has an impact on the fact that you're doing less trauma at the time of the surgery. So because you're only resurfacing part of the knee, you're causing less of that inflammatory reaction within the joint. It's less painful. You lose less blood. The rehabilitation is often much quicker. Patients at 6 weeks from a partial often look like you would expect a total knee replacement to look at 3 months to 6 months. I've had patients that come in at 6 weeks walking normally, back doing their normal tasks, walking their dog, and even going back to playing sport. There's a lower mortality. So one of the very definite things is that although it's incredibly rare to have a risk to your life having a joint replacement, it's still lower having a partial than a total knee replacement, which I think reflects the overall trauma that's taking place and the morbidity within the joint as discussed. So less swelling, less impact on your mobility afterwards. They do incredibly well with regards to getting rid of pain and function, as described in this study, and that's up to 93% survivorship at 11 years of the joint replacements. It's not an interim procedure, so I think it's really, really important to understand that a partial knee replacement is not something that you do on the way to having a total knee replacement. It's not something to tide you over before the rest of your knee wears out. This, in my mind, is a definitive surgery. There are patients that, again, you need to select correctly that have very isolated osteoarthritis and who are not developing global arthritis within their knee. You often see it in patients that have had something happen. So they've had a trauma or they've had a meniscectomy. So they've had a surgery in the past where they've had to remove the meniscus. That means that that one compartment has pathology that means that it's then degenerated. If left and you end up with a deformity like we've seen earlier, then that will ultimately have a knock-on effect and potentially cause osteoarthritis in the rest of your knee. But if you get in there and deal with that deformity and deal with that one joint compartment that's damaged, hopefully that it's a definitive surgery and it's the last thing that they have done. And that's my aim every time I do a partial knee replacement, is to make sure that I'm doing it in patients that I anticipate that this is the last operation that they require. If you are in the unlucky category or you have a joint replacement when you're much younger and that does wear out, changing a partial to a total knee replacement is a much more straightforward procedure than trying to do a revision arthroplasty of a total knee replacement, just purely because of the trauma and requiring and the bone loss and things that happen when you take out a full knee replacement versus simply taking out a small partial and then redoing what's essentially a first time knee replacement on a patient. So there's lots of different advantages to doing a partial. That's where MRI is really required, because you really want to isolate that they are absolutely a candidate for this. We know from a lot of research in Oxford, where the Oxford partial uni arthroplasty was developed, that some wear and tear in the patellofemoral joint doesn't have a massive impact on how well patients do with a partial. So a little bit of degenerate change in the behind the kneecap is not something that excludes patients from having it. This is just an example, so you can see what that actually means and how little of the joint is actually dealt with when we do a partial. This is a partial medial uniarthroplasty, so it's a medial joint compartment. So that would be a patient that has a varus deformity or varus arthritis within their knee. The femoral component, particularly if you look at that picture on the right-hand side, you can see the aim is to resurface and recreate the joint surface of the femur using that cobalt chrome implant. The tibia, again, doing the same thing. And the picture on the left shows you that gap in between is the plastic that's in there, and that's the articulating surface within the joint. So it's not just isolated to the tibial-femoral joints. So you can have a partial on the lateral side, you can have a partial on the medial side, but we also get patients that have isolated patellofemoral osteoarthritis. So that's patients where the back of the kneecap and the groove that the kneecap runs in are very, very worn in isolation. Now that's very different disease from patients that have global degenerative arthritis that's worse in their kneecaps. My practice and one of my specialties that I deal with is in a younger population of people that have unstable kneecaps that and grooves that haven't developed properly, which means that they're unstable and they don't track correctly in that groove and will dislocate and have damage to the cartilage surfaces. And very much the end point of patients like that haven't been treated or have had persistent instability are the kind of patients that present to me with very, very isolated patellofemoral osteoarthritis. Their symptoms tend to be very typical of not being able to go up and down stairs. They have to go up sideways, go up backwards. X-rays that can actually look quite normal if you're not carefully looking at them and you don't see the lateral view, like we were saying, the importance of having 2 X-rays. And that's where an MRI scan comes in to play, and you can see that the tibial-femoral joint, so between the femur and the tibia and the meniscus, is all really normal. And then the kneecap and the groove that the kneecap runs in is just bone on bone, and it's quite disabling. It tends to be women in the that are much more predominant in developing this, and they tend to be on the younger side when they develop arthritis that has an impact on their daily life. So because of that, we want to have a much less aggressive approach for these patients. So, you know, to do a total knee replacement in somebody in their late 30s, 40s for an isolated arthritis behind their kneecap is a devastating thing to do. You can imagine that although you're dealing with the arthritis behind their kneecaps and the groove that the kneecap runs in, you're also replacing 2/3 of their knee that felt normal. So a total knee replacement, like I said before, can't possibly give you the same feeling and perception of your knee as your own native knee. And so it's not unexpected that some patients would be very unhappy having a total knee replacement when they have isolated arthritis, because you're replacing 2/3 of their joint that didn't have a problem, wasn't giving them pain, with some metal and plastic. So being much less aggressive and dealing with the isolated arthritis with a partial resurfacing is really very important in the right patients. The other things that we can do for somebody who has osteoarthritis within their knee, in the patellofemoral joint, and if they're much younger, so I see patients that are in their 20s and 30s that have bone-on-bone arthritis within their patellofemoral joints because of malalignment and instability, and being able to offload, a bit like an osteotomy that we do for medial and lateral arthritis, you can do the same thing for your patella if it's all one side of the patella. So we can do what's called a tibial tubercle osteotomy. So that just means the tubercle of your tibia, where your patellar tendon attaches, we can divide the bone underneath, move that medially so that the kneecap is running in a much straighter line and offloads the lateral side of the knee the patellofemoral joint, taking some pressure off that worn out and putting some more pressure on the medial facet of the patella, the medial side of the patella, where that cartilage is better. And again, that doesn't require us to be doing a joint replacement. It's still something that can be done when they're older, and it gives them the best chance of having the fewest operations on their knee as possible. You can also use what's called a medial patellofemoral ligament reconstruction, which sounds really fancy, but it's just really medial means the inside part, the patella to the femur, and it's a ligament between the two. And again, that's just an adjunct to allow the patella to track more normally. And it's often done as part of the tibial tubercle osteotomy to help patients that have very isolated arthritis on the lateral side of their patella. If there's anything else that's causing an issue with the tracking of their kneecap that's causing that wear and tear and making it worse, or putting more pressure on the kneecap when it's moving, you can do derotation osteotomies of the distal femur. So that's rotating the femur so that the groove that the kneecap should be running in is now underneath the patella rather than the kneecap running on the edge of that, causing pain. And potentially a distal femoral osteotomy, like we described before, for lateral osteoarthritis can often help the patellar tracking as well. In that younger cohort of patients, when they don't have a groove for their kneecap to run in, that's part of the disease and part of the problem that they have, then we'll often do what's called a trochleoplasty, which is to try and deepen that groove and give them a groove for their kneecap to actually run in. So these are examples. The one on the left is the tibial tubercle osteotomy. So you can see where the patellar tendon attaches to that chunk of bone. You move that bit of bone and secure it down with 2 screws, allowing the kneecap to track in a more normal fashion. The one on the right is the medial patellofemoral ligament reconstruction. So between the patella, the femur, you've got ligament in between, and that's to help act as almost like a guy rope, or not as a restraint, pulling the kneecap, but really just stopping the kneecap going the wrong directions and help it track. Some novel techniques and things that are coming in the future, and this is one of the new studies that we in Southampton are lucky to be involved in, that's just about to start, which is the Episurf study. So this is custom small implants designed specifically for very focal defects. So if you've got a knee that's 99% good and you've had trauma, or you've had something happen, and you have an area that's maybe 1 centimeter, 2 centimeters squared of bare bone that causes you significant pain and discomfort, rather than do a total knee replacement or to do a partial where you're replacing more, all we're doing is trying to isolate and replace the bit that's actually damaged. So this study is checking to see whether this new technology is actually something that is encouraging and is going to be the future. And what we're doing is comparing doing a focal implant for patients with defects like this versus microfracture, which is trying to encourage new cartilage to fill into that defect and seeing how comparable they are. The Episurf implant is something that's quite encouraging, but there's still only maybe 500 to 1,000 ever been put in the world, and not over a very short period of time. So it's really important that that kind of implant is part of a study, and we actually have real evidence to understand that it's working. The last thing that we need is an implant like that coming on the market and people just being used as a guinea pig and they go into them. I think it's incredibly important. So that's recruiting now. And if there's any patients that you're aware of that have isolated arthritis like that might be interested in a study, then if they get in touch with us, we can see whether they're suitable for the study or not. My website, www.wessex-knee.com, has the inclusion criteria for the Episurf study if you want to look at it. It's only in the NHS, it's only in Southampton General, and we're just about to go live with recruiting for that, so that now's the time to contact us. Other treatments that patients will have heard of and often will contact us is for cartilage transplant. So there's something called ACI, which is autologous cartilage implantation, which sounds fancy, but autologous just means their own. And so you take a sample of their cartilage, send it off to a fancy lab where they multiply that up and you get hundreds of millions of cartilage cells in a little bottle, and you bring the patient back into theatre and you put those cartilage cells back into their knee where there's a defect, with a hope that that's going to grow this new cartilage. As I mentioned before, we haven't managed to really understand how to get cartilage to grow. It's not like a bare patch of grass where you can put grass seeds on it and it grows. It's much more involved in that, and we don't really understand what it is that you need to get that cartilage to regrow. So it's a bit like trying to grow grass on concrete with the snow and the temperature being 0. It's not just the grass seed that you need to have a surface that allows the grass to grow. You need to have the temperature that's right. It needs to be watered. So there's so many factors involved that we don't understand, that we're still really very poor at trying to encourage new cartilage to fill in. And even the best cartilage transplant efforts are still pretty poor. And certainly when it comes to osteoarthritis and end-stage degenerate arthritis, there isn't a solution. Unfortunately, there's not a solution even very close to being something that's a real world use. So it's very, very expensive. So to do autologous chondrocyte implantation just for the cells is about £20,000. And without any real evidence to show that it's going to make a massive impact, that's quite a difficult thing to recommend. So in conclusion, the knee is one of the commonest peripheral joints affected by osteoarthritis. As with anything, initial treatment should start on a really conservative basis and start with non-operative modalities. Do the simplest, easiest, safest thing first to get patients back on their feet and work your way up that ladder. Once you're kind of exhausted conservative measures and patients are struggling, the surgical options are there. And as you've seen from tonight, the surgical options that are there are, not just a total knee replacement. That is one option for somebody who has widespread osteoarthritis within their knee and there is nothing else. But it's not a binary choice as patients sometimes think. Understanding the difference between partial resurfacings and a total knee replacement. And I think the take homes from that are, it's not an operation for young people. It's not an operation as an interim. And as some patients will come in to me and say, oh, but if it gets worse, I might as well just do it all now and have a total knee replacement. That's not the way to look at it. If you have very isolated arthritis, you just want to deal with that one bit. You don't change all your tires just because you have one puncture. It's really, really important to understand that. Arthroplasty is a last option following appropriate patient counselling. So it's the last thing that patients should embark on, and they need to really understand the potential risks, complications and pitfalls of that, and what realistically a joint replacement gives them, which is not a normal knee. It's a knee that's had a total knee replacement. So patients need to go in very much with their eyes open as to what that means. We know now with a total knee replacement that 8 out of 10 patients have fantastic pain relief. 2 out of 10 don't enjoy having a total knee replacement, will often still have long-term pain after they've had it done. They will have, 1 in 10 will wish that they had never done it at all. So it's not the be all and end all. It's not something to go into lightly. And the key thing is patient selection. And that isn't just from my perspective, that's setting up patients' expectations every step of that journey through to have a knee replacement from primary care, making sure that you understand what it is that when patients request that review for a joint replacement, whether you feel that that patient is at that stage that a joint replacement would be appropriate for them, or whether there's another surgical option that would be appropriate. So those are the things I would think about. Questions. Now, there is the chat box that's down in the corner. I'm going to try and keep chatting while I'm here. So if anybody has any questions that they'd like to ask, feel free to do so. What I would say is that there's lots of resources online that you can point patients towards with regards to managing their knee pain, particularly just now with people still not either being comfortable to come out of their houses, not being able to actually access some of the services that we have, that I think it's really, really important to use some of those resources. So YouTube, I think, is really, really good. I'm obviously doing this through that, but if you carefully, if patients are sensible, then going on YouTube and typing in osteoarthritis, rehab, partial joint resurfacing, there's lots and lots of information out there that can educate them. My website and most of my colleagues' websites have lots and lots of information, and it's a trusted source. So with anything on the internet, it's important to understand which sources are sensible information and which ones aren't. So there's lots of different things out there. If you guys have any questions that you aren't putting up just now, that's absolutely fine. My email address, you can see, is on my website, which is again is www.wessex-knee.com. You've gone through it to get to this tonight. There's an easy form on there, so if you ever have any questions with patients, or there's anything that you'd like to know, or you feel that there's a patient that needs referred urgently and it's a struggle, particularly at the moment where you have to go through orthopedic choice or something else, if you feel that there's a barrier there and it's really important that they get in front of somebody more quickly, please feel free to email me directly. I'm quite happy with that. So we've got one question here. It says, how much pain relief in a total knee replacement comes from denervating the bone ends? I don't think very much of it's to do with denervating the bone ends. It's interesting that you say that, because there was a study that was looking at what actually drives the pain within an osteoarthritic knee. I think it's subsequently the inflammation that's caused by the uneven surfaces articulating off each other that then produce a whole bunch of inflammatory mediators that then cause inflammation and the stretching of the capsule and pain, etc. So actually taking away the surface of the bone, it's not particularly well innervated. So I don't think that's ultimately what improves your pain. We know in other things that we do in orthopedics, so for instance, if somebody has a K-wire in a fracture or a screw, actually once you kind of numb up the skin, I've done it under local, where you've taken a screw out of somebody's tibia with a little bit of local anesthetic just to make the incision over the skin, and actually the patient's not particularly sore with the screw coming out. The sorest bit is the skin. Andy Hodgson, not sure about Southampton, but Leamington has been getting more restrictive about x-rays for suspected osteoarthritis. You seem to feel radiology to confirm is important. Is that a fair understanding? Yes, I think it would be very difficult for anybody to reject an x-ray request for a patient that you have concerns of having pain without a diagnosis that's not getting better. If you don't get what you want and you feel they're not doing an x-ray, again, that's the point where I would send a referral in and say, you've got concerns about this patient, you're not sure whether it is osteoarthritis, they have night pain, they have pain that's unrelenting, you're concerned that it might be some other pathology, I would like an x-ray. It would be very difficult for anybody who gives you access to x-ray to deny that request. So I think just be forceful, and if you have any worries, then you just need to contact us directly. Even if it's not through my website or any of our colleagues, there are email addresses on the UHS main website for our secretaries. So, there's nothing to stop us nowadays just sending an email. So please do, if there's any concerns, always just send an email. Holly C, what could be the cause of knee pain on the medial aspect of the knee following a lateral partial knee resurfacing? So that sounds as if you're talking about a specific patient, but there's lots of different things that could potentially be causing that. One is, it depends how long ago they had their knee resurfacing. It may well be that they've just got residual discomfort, pain from the surgery. If it was a while ago and they've kind of healed, or it's been an old one, then they may well have development of arthritis in the rest of the joint, and they may have progressive arthritis in the medial joint compartment. Isolated lateral OA is much rarer than isolated medial compartment osteoarthritis. The other thing that's difficult about doing a partial lateral is that you naturally have more laxity and more opening of the joint on the lateral side. So if somebody has done a partial and they fill that side with too much plastic and over stuff the joint on the lateral side, then it ends up giving them a varus deformity to their knee. So you've gone from somebody who's gone valgus to varus and increases the pressure in the medial joint compartment. So it may well be that. But if you've got any concerns at all with that, then it's important to obviously either x-ray them or send them on to somebody else if there's a worry, particularly if they have a joint arthroplasty in there that's causing them a problem. So I'm going to leave it there. I'll let everybody get away and enjoy the rest of their evening. I really appreciate everybody attending. This will go onto YouTube, so if there's bits of it that you want to watch again or you want to look through the presentation again, then it's easy enough to do that. Like I said, my email address is on my website that you've had to come through to this. So if you need any information or you want to contact us at all, don't hesitate. Thanks. Good evening.